Thank you for inviting me along to speak all the way from Australia. Got here a few weeks ago, so well and truly over the jet lag. Asked to speak about how radical harm reduction can be. Always good to start with the definition. What does radical mean? So I did look this up just to be sure. And innovative, progressive, and a departure from traditional. So that's the particular definition that I'll be referring to in this talk. So I guess why I would have been asked to speak about this, as alluded to in my introduction, I was the founding medical director of this, what we call the Medically Supervised Injecting Centre in King's Cross, otherwise known as a drug consumption room, is I think the more common terminology used here in Europe, or a supervised injecting facility. It was opened in 2001 on an 18-month pilot basis. However, its trial period of 18 months was continually extended in line with 4-year political terms, such that it eventually became a 9-year trial before finally its trial status was lifted in about 2011. It remains the one and only supervised injecting centre in Australia after 15 years now of successful operation. So to that extent, it, I suppose, continues to be considered radical in that it's a departure from the traditional. And this is despite a huge amount of evidence showing its effectiveness. Both the Canadian room, which opened a couple of years after us, largely based on the Sydney model, and our injecting centre, despite being in fact latecomers to the field. The first supervised injecting centre was established in Bern in 1986, and by the time we opened there were already about 60 drug consumption rooms operating in about 6 countries in Europe. So despite Australia and then Canada being latecomers, despite the fact that our 2 centres have arguably contributed about 80% of the scientific literature showing effectiveness for this type of intervention, we were the 2 centres that struggled the most to have our trial status lifted. I know in this country there's still a lot of debate about whether or not an injecting centre might not be appropriate in various situations, and despite an inquiry, very thorough inquiry supported by the Joseph Rowntree Foundation recommending this, there is still no enabling legislation here in this country, and Canada and Australia remain the only English-speaking countries in the world with this intervention in play. Several other states in Australia have asked to have such facilities established. Other areas of our state, New South Wales, have come forward and said that they think that this would be a worthwhile thing, but there's still great political resistance. In our state, the only state with enabling legislation, the legislation actually specifically precludes more than one operating at any one time. So again, I guess it goes to the notion that this is a departure from the traditional still in terms of an intervention. I think supervised injecting facilities are best seen as an extension of the needle syringe program, which has already been discussed earlier by earlier speakers. In fact, I would argue that they're not all that radical. In fact, less radical than the needle syringe program certainly was at the beginning. They're similar to a needle syringe program in that they distribute clean injecting equipment to people who inject drugs with the intention to prevent the transmission of bloodborne infections. But as well as doing that, instead of saying to that person, okay, off you go and inject whatever drugs you happen to have wherever you're going to inject those drugs, they offer a safe clinical setting where people can inject in a controlled sort of a way with healthcare workers specially trained on hand to intervene in the event of an overdose, that of course being the most dramatic event that they very successfully can promptly respond to, but also providing a setting where people can then potentially engage with the health system and be referred on to other relevant services if that's needed. So in this sense, I think injecting setters actually accept a duty of care that the needle syringe program doesn't. But I think that by allowing injecting to occur in a facility like this, the act of injecting is not out of sight and mind. So it's right there, and it's a very stark thing, I suppose, for a government to be seen to be allowing. It certainly means that they have to maybe confront a little bit more directly the fact that they are acknowledging that what remains an illicit activity does occur, and that there are serious harms that can result from that activity when that activity occurs in an unsupervised place, and that they have made a decision that it is preferable that that activity occur in a supervised environment rather than in a back street. And so they seem a lot more radical. And I know in New South Wales, when the legislation was finally passed to lift the trial status, the actual founder or the politician who was responsible for the original passage of legislation for the needle syringe program to take place actually opposed this legislation, and he said it was just, a step too far. And it was kind of like, so what did you think that those people collecting needles were using those needles for? As one of the politicians from the other side, who happens to be a diabetic himself, said, did you think those 10,000 people were diabetics or something, that's what they were using those needles for? But anyway, he stood his ground and did not support the legislation, which was a great disappointment. Needle syringe programs, as I've said, I think they're arguably more radical. I was actually working as a part-time doctor at Kirkton Road Centre, which, as mentioned, I've gone on to be the director of for the last almost 28 years now. It was established as a primary healthcare service before the legislation for the needle syringe program was enacted in our state back in 1987. And I remember when, sort of from one week to the next, the needle syringe program was established there. So even though we'd been providing service to people who injected, we'd never given out equipment, and then we were sort of told, well, to start with, we were to give people up to 10 needles when they came in. And I remember as a doctor, it was very new and different and kind of radical, just the practicalities of that. And of course, that was when there was still a lot of community debate raging. So I do think that was quite a radical thing, in that it really was also the first time that we, reached out and actively sought to engage people who injected without any expectation that they would address their drug consumption. Of course, that is the definition for harm reduction, that it is focused on reducing harm, reducing risk. It is not specifically focused on addressing consumption, although, of course, we do use that as an opportunity to engage with people about their consumption. So whilst that's not disallowed, it's not a requirement. And I think that was quite radical for the time. We even go out, with outreach buses to actually make contact with people who have no interest necessarily in coming to healthcare services. So it was really quite new that we as healthcare workers were having contact with drug users, potentially long before they otherwise would have come. And prior to that, the attitude was that I very much remember, and I was trained through St Vincent's Hospital, which is right in the King's Cross area, right in the heart of what already in the 70s was an area where illicit drug use was happening. Overdose case after overdose case was coming in, and the sort of, the approach then was to treat these people, as harshly as possible, because maybe then they'd learn. And when asked about, why weren't we sort of referring people like this, it was kind of like, well, that sort of rock bottom thing, they just have to sort of be wanting to change, and only then is it going to, that was very much the prevailing thought. So that really swung around 180 degrees, and you have to, of course, ask why that is. But yes, as mentioned, it's now pretty much a mainstream activity. Needle syringe programs are present in more than 90 countries around the world. In Australia, they're largely in the government health sector, and so I would certainly say that this is an example of how which shows that you can in fact be quite radical in certain circumstances. So it begs the question, what are those circumstances? Well, having a crisis, it would seem, really helps. So an imminent threat to the health and well-being of the general community, in this instance anyway, certainly led to political courage. And I do, as you'll see there, I've highlighted general community. I don't want to sound too cynical, but I think it was the concern for a generalised epidemic. It was appreciated at that early stage that HIV was not going to stop in this drug-using population, that through sexual transmission it would move into the rest of the population. There was huge fear about AIDS, of course, at that stage, no cure available. We didn't know how big this was going to get. And so I think that, that sort of fear right across the community allowed people to put to the side their sort of moral concerns that, addiction was the big enemy, and, put front and foremost that we needed to be pragmatic in our approach and actually deal with the here and now, the reality, and actually give out needles, at least, to reduce the risk that HIV would be transmitted. At that early stage, we didn't fully appreciate that we were right in the midst of a hepatitis C epidemic. Later on, when a test became available so that we could start measuring that, we also realised that this, of course, was a really key intervention also to prevent that and hepatitis B, all of which are bloodborne infections. In the case of the injecting centre in Australia anyway, the impetus for that was a heroin overdose epidemic. So in the late 90s, heroin had become incredibly cheap, very, very high quality, and the death rate across Australia had exceeded the national road toll. King's Cross area in Sydney was the area where these overdose deaths were the most concentrated. It was at levels where, dare I suggest, even politicians, relatives were suffering heroin overdose death as well, because heroin had become so cheap. Young people were taking it up at a rate of knots. And so this really did cause great concern, leading to a parliamentary drug summit, during which 172 resolutions were actually passed addressing all aspects of illicit drug use in our state. But the one resolution that got the front page attention was the proposal to establish what was then termed through an amendment the medically supervised injecting centre. We were never allowed to use that terminology, drug consumption room, lest people think drugs were being consumed there. Clearly, these two crises were important in leading to the political courage necessary to take these radical steps to allow these two radical approaches. But conversely, of course, the end of such a crisis can arguably also be a threat to innovative approaches. And I remember being at a conference some 10 years ago, and Dr. Ambrose Hagen, sorry, my pronunciation is wrong, one of the founders of the heroin-assisted therapy trials in Switzerland, talked about that it was a potential threat to harm reduction was the success of these programs, the fact that an HIV epidemic had been averted, the fact that treatment was now highly effective, that it meant that we could see the rise again of morally driven views in relation to what should and shouldn't be allowed in the community. And I think that's very true, certainly in King's Cross, the fact that this injecting centre drew in a lot of high visibility injecting, along with the other related activities, into a clinical space, and the area has actually gentrified a lot in the last 10 years, means that there are now people saying, well, do we really need this thing? It's a temptation to think that we just need to excise this facility and we'll get rid of the drug problem from our area altogether. So we have to constantly argue that, well, if you close these doors, the 200 injecting episodes that are occurring here each day, nice and quietly and privately, will be back on the streets and affecting amenity, not to mention, of course, resulting in overdose deaths when such activities occur in an unsupervised situation. So I would certainly recommend, though, that you make the most of your crises when and if they occur, and always be at the ready to sort of jump through the window, because you also don't always know when they're going to happen when you're a public health practitioner. But then once you've done that, you need to bed down these initiatives and be aware that they are always at risk of being a victim of their own success or of changes in economic situations, as the last speaker so very eloquently demonstrated. And we need to ensure that these approaches become part of normal core business. Further on this, the risk, I think, when they are established in a sort of crisis situation is that they're inevitably politicised from the start. And there is a risk in those situations that you either get policy overreach or underreach. They're also at risk of in that sort of crisis situation, that you're not really thinking in terms of the long term. So in our situation, say for example the needle syringe program, the way that was enabled in New South Wales and most of the states in Australia was not to decriminalise drug use and also therefore possession of drug-related paraphernalia, which of course is what we as public health physicians think would be the obvious thing to do, but the existing laws criminalising drug use and so on were left in place, but an exemption was given so that certain categories of healthcare workers could give out needle syringes without being at risk or being charged with aiding and abetting a crime. What this now means is that a drug user themselves can't actually give a needle syringe to another drug user. And we know, particularly for hepatitis C, we need to get coverage rates right up near 100%. As mentioned, not every drug user thinks our services are so marvellous that they will cross across the city to come to them, even though that, we're often accused of having a honeypot effect. We dream of that ourselves. But in fact, that doesn't happen. And an obvious way to increase coverage is through the privilege access that other drug users have with their peers, and to be able to actually arm them with both the information and the equipment to be able to pass on to people often early in the piece before they've ever even thought of coming to an HIV prevention service. But at this point in time, that is not allowed. Also, the exemption only allows for us categories of workers to give out injecting equipment. So whilst we might like to promote or encourage non-injecting modes of drug use, it would be illegal for me, for example, to give out a glass pipe for methamphetamine chasing. Because it's only injecting equipment. So there are examples of where the initial legislation, which was just focused on HIV at that time, that didn't need the sort of coverage that we now need for hepatitis C, wasn't so, focused on other types of drugs and so on, has not proven to be particularly robust. Also in that situation, I would strongly advise not to promise too much. I think that can sometimes be tempting for us. We get this window of opportunity and it all looks great. And then, for instance, with the injecting centre, the way they decided to sell it was not so much just to save lives, which I would have thought was enough, but to get people into treatment. And whilst, what's not to like about that, as it transpires, the fact that a few years down the track, not every single drug user in King's Cross had been cured, was something that was thrown back at us. It's like, well, you said you were going to engage with people and get them into treatment. It's like, yes, well, we can take the horse to water, but it's not always so easy to get them to drink. And so, I had the opposition leader saying when he was about to become Premier of our state that, I sort of get what you're doing here, but clearly, they oversold this whole thing of getting people into treatment, even though you have actually affected thousands of referrals into treatment. The fact that there's still people using drugs here shows that, well, that was a failure, and so, I'm not going to support this. So I found that with this thing of evidence, and I suppose this is making sure that there are very realistic outcomes at the start and not sort of over-promising is a very important thing. There we go. So how to get innovation happening. Ideally, this should be in non-crisis times. The reality is it does need to be politically safe. It would be nice to be able to operate outside of politics, and there have been moments where I must say I've actually envied China. I know the previous speaker talked about China. They certainly managed to implement methadone treatment faster than any other Western country stuck with democratic processes which involve community consultation. They just rolled it out. They looked at the evidence and went, yeah, that looks pretty good, rolled it out. Mind you, the quality a little bit wanting, so it's not quite so simple. But yes, the political realities is that the benefits certainly need to outweigh the costs. And again, we're looking at broad community here, not just drug-using community or affected communities. I think we have to be realistic that politicians are voted in by the broader community, and so certainly these initiatives can't be seen to harm the community, or the harms at a minimum need to be manageable. They also need to have community support, and community support is not something that you can do overnight, so it's important for initiatives to be working with the community all along the way, so that again, when that little window opens, you can jump through, and it's not a case of the community going, what? An injecting room, gee, what does that involve and where's that going to be located? Next to my home? I don't think so. So those sorts of things, you need to be doing the groundwork, the community development work in a long-term sort of a sense, so that you have a largely educated community, and that's very ongoing, particularly in areas where there's high turnover. Our area turns over 50% every 4 years, so it's, every new group that comes in needs to hear about and understand why we need to have these services and what how we also are very responsible at managing some of the harms. I've certainly found as a director of these services it has not paid for me to minimise things, whilst I can certainly point at the evidence that we are not a honeypot. There is no doubt that drug users have to come to our service, so they actually are seen in the vicinity. And I've ended up having to have some tough conversations with people when they sort of start talking about sensibilities, like, well, there's a whole cluster of drug users standing around over there. A bit like the vaping, we're not sort of like all that comfortable seeing people vape. And I've, personally sort of said, well, I'm sorry, but, we can't sort of have these people combusting. They do exist, and if you find it slightly offensive to see somebody who's not necessarily well-dressed and whose language is not always lovely, I'm sorry, but, these are human people. So I do think that as well as talking about evidence, we need to get down to values and morals, and this was a harsh, lesson for me anyway, who does very much stand at the altar of science, to realise that arguing science and evidence wasn't going to sort of get us there in the end, and we needed to get down and dirty and talk about values and really confront people about, what it is exactly that bothers them about seeing, 4 drug users standing over there having a powwow, even if it is that they're on their mobile phones organising their next deal. How is that bothering them? So piloting can be good and certainly reassuring to people so that things are not cast in stone, but you also need to set, as I say, realistic outcomes. Don't promise too much. and also have an exit strategy. I'm still sort of suffering from post-traumatic stress after what became a 9-year trial. 18 months, I think, would have been perfectly adequate, and so 9 years is clearly ridiculous. So I'll finish on saying that, reiterating that I do actually think that radical harm reduction approaches can be successfully advocated for. I think that where possible, it needs to be demonstrated that they are for the greater good, or certainly don't cause harm, or that those harms are manageable and that they're worthwhile, and also that they can be, supported over the long term. I think it's also really important within the field that we speak as one in these instances. I think sometimes the problem with experts is that we get a little bit stuck in some of the esoterics, and we argue with each other publicly, and if there's one thing a politician, that provides a very nice excuse to politicians to say, well, look, even the professional field isn't at one on this. Ideally, again, I think it's important that affected communities be part of that voice, so that we stand there together and communicate what is good for the greater good, that we use evidence, both scientific, but don't forget that morals and values are important increasingly in this day and age, and call it for what it is. Our biggest opponents of the injecting centre, apart from, the Vatican and the UN and the Prime Minister, were Christian fundamentalist organisations. Our injecting centre was actually auspiced by Uniting Care Church. The government didn't actually, unlike with the needle exchange, have the courage to step up the plate itself. It did fund it, but it put it under a church organisation, and it was the Christian fundamentalists that attacked us nonetheless. And the Uniting Care Reverend to whom I reported, he said, Ingrid, he said, these people don't drink tea and coffee. You really think that they're going to sort of come at people injecting heroin into their veins? And it was a sort of a good eye-opener, I suppose. But it did lead me then to being more and more explicit when I spoke, to say, okay, look, I respect and I am very tolerant of other people's views. This group of people here apparently think it's, better that people die than live with an addiction. They are comfortable about the idea that this service should be closed and that these people should be back in back lanes dying in those circumstances. I, at least as a doctor, although we don't have the Hippocratic Oath in Australia, am not comfortable about that. So, I think it's better that we actually keep people alive, and I make no apology for it. Thank you.